Thank you, Chairman. It is my great honor to present here. Today's my talk is how to minimize the risk of early graft failure and management of PGD. So I think the early graft failure is a kind of nightmare for the cardiac surgeon and cardiologists just after transplantation. So maybe my talk is about the primary graft dysfunction, I think. This is called PGD. Before 2013, there's a big pitfall in the PGD research and PGD in real clinical practice because most major cardiac transplant centers use different definition and parameters for cardiac function. And so there is difficulty comparing published reports about PGD and no agreed protocol for management. So in 2013, many experts about the PGD met together and they discussed and then they reported the consensus report from the ISHLT on the primary graft dysfunction after cardiac transplantation. So today my talk is mainly focused on this consensus report. So let me start with the fact check. Before the meeting, they are online survey about the 57 centers from in 2013, and they surveyed some questions about the primary graft dysfunction. So they collected the data and they surveyed. The results showed that the prevalence of a PGD was about 7.4%. And the 30-day mortality was about 30%, and one-year mortality was 35%. It means that PGD is very correlated with early mortality just after transplantation. And most common cause of death in PGD patient is multi-organ failure, and the next one is graft failure. And most centers define PGD as air ejection fraction below 40%, and most centers define PGD. It is started PGD within 24 hours after transplantation, and most experts think that the mechanical support is a mandatory criteria for the definition of a PGD. The important thing is the PGD, it is called primary, so they have to exclude some of the other causes of graft dysfunction, such as hypoactive rejection and sepsis, or right ventricular dysfunction with the pulmonary artery pressure increased level, or some bleeding. So we have to consider this kind of the other factor for decreasing graft dysfunction. So they usually have precaution against PGDs like this, and they usually treat retransplantation, or they usually use mechanical support such as IABP, ECMO, and BAT. It is very well reviewed by Dr. Redley. So in this consensus report, they classified the graft dysfunction. The first one is primary graft dysfunction. PGD has two subtypes. The first one is LV type. This is called LV, or biventricular dysfunction. And the second type is the PGD with RV. It's just only RV failure. And the second thing is the secondary graft dysfunction. So it should be exclude the other cause, as I already mentioned there. So what is the risk factor for this PGD? In this consensus report, they reviewed all the report regarding the risk factors for the PGD. So they summarized donor risk factor and recipient risk factor and surgical risk factor. So let me start with the donor risk factor. As you already know that increased age, it is very important, and cause of death of donor, or some trauma, or the cardiac dysfunction in donor, or some increased inotropic support in donor. Or maybe the other thing, there is very interesting thing, some experts measured the troponin level, and the increased troponin level in donor may be related to the PGD. There are some reports, especially in the current area, we use high sensitive troponin. Maybe it can be more helpful for for defining the PGD in donor patient. And the second thing is the recipient risk factor. Age is also important. Weight is another factor, and the mechanical support is a very important risk factor. And interestingly, the congenital heart disease as a etiology of heart failure, it is very important for the risk factor for the PGD. And some multiple reoperation history, it is also important, and allosensitization or infection status or retransplantation is a very important risk factors. And the other thing is the surgical procedure risk factor. As you can guess, the ischemic time or donor recipient, gender mismatching or weight mismatching, or there is combined non-cardiac organ donation, it can increase the time of operation. So it can be increase the risk of PGD. So usually PGD could be rated increased early mortality after transplantation. So if the early mortality maybe come from the PGD, so in this report they reviewed the 30-day and 19-day mortality regarding the etiology of the heart failure. So as you can see, congenital etiology is a very high risk for the PGD, and the second thing is the valvular cardiomyopathy. And the third one is the lead heart transplantation. And the ischemic and non-ischemic, the early mortality is relatively low compared to congenital and valvular etiology transplantation case. And let me move to pathophysiology. Let me summarize the pathophysiology. It's just two components. The first one is a series of insert by operation, and the second one is a hostile environment of recipient. So there can be some insert during heart transplantation operation, some we usually use the brain death donor, so there may be some sequelae in donor or hypothermic ischemia or warm ischemia during surgery or reperfusion injury after release of aortic cross clamps. So it can be some insult for the organ. They also collected some data of PGD patient in autopsy sample. This is very interesting data, and the autopsy result shows that the most common reason is the reperfusion injury or reperfusion ischemic injury. This is the most common reason of PGD in autopsy cases. And the second one is the myocyte necrosis. And the third one is the multifocal edema or hemorrhage. It can be related to rejection, but the rejection pathology is relatively very low. It's just 7%. So there may be another mechanism for the PGD rather than the rejection itself. So PGD in clinical practice is a diagnosis made with use of imaging or hemodynamic data. It can be related to some very clinical, it needs some clinical decision rather than the pathologic decision. So most surgeons or most cardiologists have very suspiciously focus on the status of immediate post-op cases. So they recommend some preventive measure to decrease incidence of a PGD, such as donor management, or better matching, or better preservation, or better for organ, or some cases they want to use the nitric oxide for decreasing the increased pulmonary artery pressure, or they want to decrease ischemic time or transfusion requirement. It is the preventive strategy for decreasing PGD. So they also suggest a new definition of PGD. This is a new definition of a PGD. It is suggested by the committee. So they divided into three subtypes regarding the severity. The mild group is just the ejection fraction decreased below the 40%, and hemodynamic parameter increase RAP or wedge pressure and the decreased cardiac index. The moderate type is this mild subtype combined with the hypotension with the mean arterial pressure below 17, and the severe type, it is dependence or some mechanical support. And the other thing is the right ventricular dysfunction. It is summarized here. So they published this kind of new definition. So following this new definition, some expert reported very interesting data. This is the epidemiology of a new definition of a PGD. This data is from the Italy. It was just recently published last year. And they collected the data in their hospital. They showed that increased prevalence of the primary PGD by the definition of a new definition. So in early 20, only the prevalence is just about 7%, but near 2010, the PGD prevalence was increased about 20%. And they also find some very interesting predictor for the PGD. So female recipient and the congenital heart disease etiology and pre-transplanted anemia and pre-transplantation increased PVR. And the donor factor is a female donor or undersized donor or increased ischemic time can be related to the increased risk of PGD. And the other report from the Duke also suggested the instance and trends of PGD by new definition. It is just published in AJT. But currently, they reported that PGD instance was not significantly increased from the 2009 to 2015 in their hospital. Next one is how to manage PGD. It's very simple. There are very simple and two kind of management we have. The first one is medical therapy. The first one we usually use the inotrope and we can use the vasodilator. And the second one is the mechanical support such as IBP or ECMO and ERVA. So in the consensus report there are some recommendation of some big hospitals approach. The first one is the Cedars-Sinai, and they reported that their instance of PGD is just about 2%. The first time that they excluded anatomic problems such as the anastomosis narrowing or kinking, and they maximize inotropic support in operation room, and the cardiac index decrease or they may find some evidence of PGD, they first use the IBP. And then to maintain cardiac index above 2.5, they implant ECMO, and then the vital sign was stable and they reduce the inotropic dose. Or they can implant LB banting or they maybe switch IBP to Impella. And then they usually hold the intravenous heparin for the 24 or the 48 hours, so they find no bleeding sign. Even though they use the ECMO, they have to keep their ACT level just about 116, and then reassess the LV function every 2 days. This is from the citizenry approach. And the other reports from the Germany, they report their instance just about 1%. They first use the levosimendan, and then they use IBP or ECMO, and they also use the Levitronics CMEGA device. I think it is very similar to the tandem heart in the United States. It's a very small pump, and they usually use the bath. So let me review some up-to-date publication about the PGD. This data is from the Columbia University. They compared the two mechanical support therapy for the PGD. The first one is ECMO and the second one is VAD. As you can see, the ECMO survival is higher than compared to the VAD survival, because usually ECMO patients just use the shorter duration compared to VAD patient. And in VAD patient, the major morbidity such as the stroke or sepsis or major bleeding was increased. So it can be related to increased survival in the VAD therapy. And the other interesting report is about the amiodarone. It is also this report is also come from the Columbia University, and they reported that dose-dependent association between amiodarone and PGD. In this report, they just found some trend to decrease cumulative survival in amiodarone group, and they also reported that in-hospital mortality was tended to be higher in amiodarone group. But interestingly, they analyzed the day of hospitalization dose of amiodarone, and it is very well correlated with the instance of severe PGD. So if your patient used the amiodarone, at least you have to stop the amiodarone on the day of hospital transplantation. And they also reported that there are very big, very well correlation between the severity of PGD with the cumulative amiodarone dose. As you know, the amiodarone half-life is very long. It's about 1 or 2 months. It can be related to the increased risk of PGD. And this data from the Duke University, they also reported that they analyzed some risk factor for PGD. In their report, they also found that recipient amiodarone was also important risk factor for PGD. So we have to focus this risk of amiodarone in the pre-transplantation setting. So let me perspective. You know, the PGD instance may be increased gradually because we use more elderly donor and more elderly recipient. So the increased age can be a very important risk factor. So we may experience more prevalence of a PGD in our real practice. So we have to pay more attention to the PGD. So let me summarize my talk. The first thing is the PGD. So how to minimize for the PGD. There are some risk factor about donor or recipient, so operation by itself. So we have to harmonize and manage for this kind of 3 factors. And interestingly, the etiology, especially congenital or valvular origin cardiomyopathy, is very important. So when we operate transplantation for this kind of congenital or valvular disease, we have to be very suspicious of a PGD. And the second thing is the amiodarone use and how to manage the PGD. So we are very closely monitoring the patient status. And then we have to early use of inotropics and early use of mechanical support is very important for the increasing the survival in the patient with PGD. Thank you for your attention.